Welcome, everyone, and good afternoon. My name is Beverly Lofton. I'm a senior policy advisor with the CMS Division of Tribal Affairs at CMS. This webinar today is in collaboration with the Division of Tribal Affairs at CMS and the CMS Center for Medicare. During this webinar, our presenter will provide an overview of the Inflation Reduction Act of 2022, and specifically the new Medicare Prescription Drug Inflation Rebate Program and the Medicare Drug Price Negotiation Program. Any materials related to this presentation can be downloaded from the Spotlight page of the CMS American Indian and Alaska Native Outreach and Education website, and that can be found at go.cms.gov/AIAN. The website link will be added to the chat feature of this webinar. We are pleased to be joined on this webinar by John Koster from the CMS Medicare Drug Rebate and Negotiation Group. At this point, I will now turn the webinar over to John to begin the presentation. John?
Good afternoon, everybody. My name is John Koster. I am a pharmacist, and I am a senior technical advisor in a new group in the Medicare program called the Medicare Drug Rebate and Negotiation Group. And the purpose of today's call is to talk about some of the changes that have been made by the Inflation Reduction Act of 2022. This was a law that President Biden signed last August, and it made some significant changes to the Medicare program. We're not going to talk about all of those changes today, but you'll be hearing more about those changes. For example, it redesigned the Medicare program in part to, over time, close out the donut hole. It's made some changes in the way that individuals can pay their cost sharing for drugs. But today's webinar is going to focus primarily on two programs that our new group in Medicare is working on implementing. One relating to new rebates that drug manufacturers have to pay to Medicare on certain Part B and Part D drugs if those prices increase faster than inflation. And then we're also going to talk about a new negotiation program that was established where CMS or Medicare will begin to negotiate directly with drug manufacturers for the prices of certain prescription drugs starting this year, but the prices will go into effect starting in 2026. So we've been working hard since last fall in trying to put these two programs into place. So just as a little bit of background, as you know, Medicare has been around a long time. Medicare only got a drug benefit in 2006. So, Medicare has been around since 1967. It only had an outpatient drug benefit developed in 2006. Congress enacted it in 2003 in the Medicare Modernization Act, and it came online in 2006. And that's helped millions of Medicare beneficiaries gain access to prescription drugs. Now, before that, Medicare beneficiaries did get their prescription drugs through different ways, but since 2006, Medicare beneficiaries have been able to, that want to stay in Medicare Part A, the hospital part of Medicare, and Part B, the physician part of Medicare, they can opt into a Part D, which is the drug benefit program. If you don't want to take Medicare A, B, and D, you can also opt into a Medicare C, which is the Medicare Advantage program, which is like a managed care program where you get all your healthcare services from a single organization. So what we're going to talk about today are some of the changes that were made in Medicare relating to how CMS will start collecting rebates from drug manufacturers for the prices of their drugs that are paid for under Medicare Part B and Part D. And we issued guidance on that in February of this year. We solicited comments on that. and we will be issuing revised guidance later this year on those particular inflation rebate programs. For the drug price negotiation program, we issued guidance in March. We solicited comments on key topics and will be issuing revised guidance this summer. Now, why is this an important issue? Well, beyond the fact that these are major changes to the Medicare program that will affect all Medicare beneficiaries, in particular for this group, there are multiple places in these two programs, the inflation rebate program and the negotiation program, where there's implications or intersection with the 340B drug pricing program. Now, I know many entities on this call purchase both from the federal supply schedule, purchase their pharmaceuticals from the federal supply schedule, but they also can participate in the 340B drug pricing program. Now, this is a program that was established many years ago in 1992 to help certain federal grantees and certain hospitals buy lower cost pharmaceuticals. It essentially was a program that helped to make drugs more affordable for certain federally funded clinics, certain federally funded entities, Indian, tribal, urban organizations, as well as disproportionate share hospitals and others. There is intersections with the new Medicare drug rebate and negotiation program and the 340B program. And today's call is to begin to socialize and sensitize you to what some of those changes are and what that intersection might be. So just to put it into context, some of the changes that you should be aware of in terms of timeline. So, as I said, the law was enacted in August of 2022. The Part D manufacturer inflation rebates, those started last October. Now, we haven't started collecting them yet from manufacturers, but they began last October, meaning manufacturers for drugs that are dispensed to Part D beneficiaries are potentially liable for inflation rebates on those drugs if the price of those drugs increased faster than inflation. So that's the first program that went into effect that we're going to talk about today, back in October of last year. In January of this year, the Part B manufacturer inflation rebates began. Now, Part B, as I said before, is part of fee-for-service Medicare, and in their Part B, beneficiaries can get a drug, an infused drug, an injected drug under Part B in either a hospital outpatient department, a physician's office. These are primarily infused, injected medications covered under Part B. There's also a rebate program in place now for manufacturers of Part B drugs that went into effect in January. And again, we're not collecting these rebates yet from the manufacturers, and I'll explain a little bit more of that as we go through these slides. Now, one implication of the rebates that manufacturers are paying under Part B is that, as many of you know, when a beneficiary receives a Part B drug from a physician or other practitioner, generally, if they don't have either Medicaid, which wraps around the cost sharing, or additional private coverage for the 20% cost sharing, they will pay 20% for that drug. That's the Medicare Part B cost sharing. If, however, under this program, if the drug, the Part B drug, had inflated faster than inflation for the last quarter, the cost sharing for that drug will be based on what the price would have been for the drug had it only increased by inflation versus what the price actually is. In other words, the beneficiaries will share in some of the inflation rebates that we will be collecting on these drugs. So their cost sharing will be reduced. We published the list of the first set of drugs for April 1st, and we're going to do this every quarter. If you look in the Part B drug file, you will see those Part B drugs where a beneficiary Part B cost sharing reduction has occurred as a result of the fact that the manufacturers have increased their prices faster than inflation on those drugs. So the beneficiary will benefit by paying the 20% on a lower amount. In September, we will publish the first set of Part D drugs selected for negotiation. So the negotiation program is different than the rebate program. The negotiation program for Medicare will be first for the first 10 Part D high spend drugs. And again, we'll talk a little bit about that as we get into the slides. Those will be identified later this fall on September 1st. And over the next couple of years, we will negotiate with manufacturers over the prices of these drugs based on certain criteria and elements that are prescribed in the law in terms of how we're supposed to negotiate. So this fall, we'll publish the first set of Part D drugs that will be subject to negotiation. Now, while these are high spend drugs in Medicare, there are also drugs that have been on the market for at least 7 years where there's no generic competition. So as many of you know, brand name drugs come to the market. They generally enjoy a period of exclusivity where there's no generic competition. And that's to allow the manufacturer to recoup some of the investments it made in the research and development of the drug. And then a natural life cycle of a brand drug, at some point, the patent will expire and the product will go generic, meaning the other competitors, generic competitors, can come to the market, and that will help bid down the prices of those drugs. It creates competition and bids down the prices. Well, the drugs that we're going to be negotiating over will not be the ones that just came to the market. These will be the drugs that are still highly used in Medicare, but where there's no generic competition, meaning the prices are probably higher than they should be, thus creating more spending for Medicare beneficiaries and more spending for Medicare. So as we'll release this first set this fall, you'll see what those drugs are. And then we will publish in 2026, if we go down the slide a little bit, you'll see on January 1st, 2026, the MFP for that first set of top 10 Part D drugs will go into effect. Now, many things will happen in between this September and January. We'll be negotiating with the manufacturers. We'll be publishing those prices in 2024, so everyone can get ready for 2026. But then it will also have another set of 15 Part D drugs, the next set of high spend Part D drugs. The maximum fair price for those drugs will go into effect in 2027. And then in 2028, we'll also be negotiating for Part D and Part B drugs. So, as I said, this September, we'll kick off the process by publishing the first set of 10 Part D drugs. We'll be negotiating with the manufacturers in the end of this year into next year. We'll publish the first set of prices next fall. Those will go into effect in 2026, and then we'll repeat the cycle again, so that over time, we'll be adding to the number of drugs for which Medicare is negotiating prices. And these negotiations will benefit Medicare and Medicare beneficiaries, because these prices will become the prices that will become the basis for the cost sharing that Medicare beneficiaries will pay when they go to the pharmacy counter. And for Part B, they will become the basis for the prices that the providers get paid. So that will reduce the payment to providers for Part B drugs, as well as the cost sharing that beneficiaries will pay. So these are the key milestone dates for the negotiations. This is a high-level summary. There's many, many other dates in here to get us to the goals and the outcomes. But this fall, you will see us put out our first top 10 Part D drug list that will be subject for negotiations with the manufacturers. So let's go back to rebates so I can explain how the Part B and Part D rebate program fits into some of the 340B issues. So as for the rebates, manufacturers of certain Part B and Part D drugs whose prices rise faster than the rate of inflation must pay back the difference to the Federal Supplemental Medicare Insurance Trust Fund. So what this means is that manufacturers whose drugs are used in Part D and Part B, in mostly for brand name drugs, those prices cannot increase faster than the rate of inflation as measured by the CPI. And that is not that's a program that the CMS is very familiar with. Those types of inflation rebates are used in Medicaid. They've been used in Medicaid since 1991. Other federal programs also have inflation, either rebates or caps on prices that can be charged. So Congress decided that it wanted to cap the rate of price increases for Medicare Part B and Part D drugs, mostly for brands. Now, these rebates will not go back directly to beneficiaries. They'll go back to the Federal Supplementary Medical Insurance Trust Fund. So it helped to extend the life of the trust fund. So how are we going to calculate these rebates? Well, we are going to monitor drug prices during the period of time the rebates will be billed. We'll compare them to a benchmark price. We'll adjust that price for inflation. We'll take out certain drugs that will not be subject to rebates, like drugs that are in shortage, and we'll invoice manufacturers for the remaining difference. I don't know that you have to be so concerned about the mechanics of how the rebates are going to be calculated or billed. I think what's important to know in that in both cases of Medicare Part B and Part D inflation rebates, Congress instructed us to exclude from the billings to manufacturers those products that were dispensed with 340B purchased drugs. So the bottom line here is that the manufacturers should not be paying both a manufacturer inflation rebate and a 340B price on Part B drugs subject to inflation rebates and Part D drugs subject to inflation rebates. And as it says here, it's to avoid manufacturers paying a Medicare inflation rebate and a 340B discount on the same drug. So Congress instructed us in the statute that when we do the billing, so for example, if someone comes into a hospital that is a 340B hospital, they bought the product at a 340B price, and that's dispensed or administered to a Medicare beneficiary, that particular product should not be subject to a Medicare inflation rebate because it was already purchased at a 340B discount. Same thing if a physician's office, is eligible to participate in 340B because it's part of a hospital system or a hospital outpatient department. We are to identify and exclude those 340B units from rebate billings. Now, how we do that, that's what we also want to discuss today. How do we avoid us billing a manufacturer for both an inflation rebate and a 340B discount? That is, if the drug was dispensed or administered and it was a 340B acquired drug, how does it come out of the rebate pool? So for Part B, again, I don't know that you have to be familiar with or understand the mechanics unless you really want to. But rebates for Part B are calculated every quarter. So beginning January 1 of this year, we'll be billing manufacturers for rebates for Part B drugs on a quarterly basis. We have to bill them within the end of 6 months of each quarter based on the utilization of the drug, and the manufacturer has 30 days to pay the rebate. So at the end of every quarter, we will look to see in our utilization files in Medicare how many units of a particular Part B drug were paid for by Medicare in that quarter. We will then have to pull out from that those units that were billed that were also purchased under the 340B program. So as it says on the third bullet, the bolded bullet, units purchased under the 340B program are to be excluded from the rebate billings. we issued guidance at the end of last year on how this policy would be implemented for 340B hospitals and other providers. And that is because Congress instructed us to take out from the rebate billings beginning in January of this year any unit that was also purchased under the 340B program. So technically, units being billed this year to Part B that are also 340B would have to be excluded from the utilization pool when we start billing rebates. Now, we have some flexibility in the time in which we bill rebates. We don't have to bill rebates for Part B inflation, these Part B inflation, Part B drug inflation rebates until September 2025. So we have some time. But the units that are being billed to Medicare today that are also purchased under 340B are to be excluded from the rebate billings. And as I said, one of the benefits for Medicare beneficiaries is beginning April 1, if the Medicare payment amount for a quarter exceeds the inflation-adjusted payment amount. In other words, if the benchmark payment amount inflated by inflation is less than what the manufacturers are reporting to us as their average sales price, which is the basis of Medicare Part B reimbursement, the beneficiary will pay the lower amount, which also helps them pay less out of pocket because it's a lower 20% of a lower amount. So at the end of last year, at the end of 2022, recognizing that in 2023, we had to exclude from the rebate billings for Part B any drugs that were it's also subject to a 340B discount. We issued guidance at the end of the year, and the guidance link is up here. You can see it, and there's a new section of the Medicare.gov website where we have exclusive documents and guidances relating to the new rebate program and inflation and negotiation program. There's a requirement for all Medicare providers and suppliers, hospital and non-hospital based, to use 340B program modifiers that we published in the separate program instruction, which is linked below. Now, we recognize that many hospital-based 340B providers, 340B-based hospital providers, have been using these JG or TB modifiers over the years to identify 340B claims. These had been used for many years for payment purposes. So the hospitals, most of the hospitals have been familiar with these modifier codes. While they're not being used anymore for reimbursement purposes, we are going to continue to use them. And we did instruct the hospitals to use these for 2023, to continue to use these to identify 340B claims. So for 2023, the year we're currently in, we intend to remove units in all institutional claim lines that were billed with JG or TB modifiers. Now, if you were a hospital that wasn't used to using these modifiers before for reimbursement purposes, and there were several that were not, what we're going to do for this year is we're just going to remove all your units to be on the safe side, assuming some of them are 340B and some of them are not. But if you were using the modifiers before, and you'd continue to use them into 2023, if you were not, then we're going to just take out all your units. But starting in 2024, every 340B provider, hospital and non-hospital based, has to use these modifiers so that we can fulfill the intent of the law, which says we are not to bill hospitals, we're not to bill manufacturers for inflation rebates for drugs that are also subject to 340B discounts. So we're giving 340B providers time to either modify their systems, become familiar with modifiers. And at this point for 2024, you would either use a JG modifier or a TB modifier. And I would suppose for most hospitals and clinics on this call, it would be JG. TB would be used for rural children's hospitals and PBS exempt cancer hospitals. Now, you may have specific questions about these modifiers. how they're going to be used in different 340B entities, and we'll try to answer questions, say, if we can. But the instruction, again, the program instruction, the document is listed here with the link. For this year, if you were not used to using modifiers because you were not a hospital, since most of these were being used in hospitals, then we'll be excluding all your units. If you were a hospital that was using them, then we'll be excluding all institutional claim lines that were billed with the JG or TB modifiers. So again, this is the Part B instruction with respect to taking out from 340B entities claims that are filled for Part B drugs with 340B purchased products. And this is to avoid having a duplicate discount. Now for Part D is a little bit different. Just like Part B, we're supposed to bill manufacturers for Part D inflation rebates, and that is no later than 9 months at the end of each applicable period. Now, in Part B, a rebate period is a quarter, calendar quarter. In D, it's a calendar. It's a full 12 months, not a calendar year, but it's a full 12 months. And just like in Part B, manufacturers have 30 days after we bill them to pay the rebates. And again, for the first two rebate periods in Part D, we have until 2025 to bill for rebates. So again, that's just program stuff that is of interest to you possibly, but doesn't doesn't have anything to do with 340B. However, just like in Part B, where we were instructed to exclude 340B purchase units from the Part B rebates, we were also instructed to exclude from Part D inflation rebates those Part D claims that were filled with 340B units, either through the covered entity itself or through one of your contract pharmacies. Now, we don't have to do this till 2026. So for B, these have to be done starting this year in January. For D, we don't have to do this until 2026. So there's still 2.5 years before we have to take out from the Part D rebates any Part D claims that were filled with 340B drugs. So it's very possible that claims being filled right now with 340B drugs may also be inadvertently billed for a Part D inflation rebate. But Congress did not instruct us to do anything or develop a mechanism to take those claims out. But we will have to determine a mechanism to accomplish this exclusion prior to 2026. Now, we put out rebate guidance, as I said before, in February for Part B and Part D, and we did propose in that guidance that in order to identify Part D claims that were filled with 340B drugs, we would ask that the pharmacies place or the plans place some sort of modifier on the claim to identify them as 340B. So as you know, Medicare for Part D collects a set of data called prescription drug event data. There is no modifier or identifier on the PDE record now of whether a claim for Part D was filled with a 340B drug. Those can be included as part of the PDE record. The issue is whether that's the best way to do it. How do we identify claims filled with Part D claims filled with 340B drugs? We understand and know for many, many years that oftentimes, at least in the contract pharmacy situation, the pharmacy doesn't know it's a 340B eligible patient until many weeks or even sometimes months after. So how does the modifier then get on the claim? As I said, we did include in our guidance that we would require a modifier be placed on the claim. Whether that's the best way to do it or not, we'd be open to suggestions, and we're going to publish a final guidance, release a final guidance on this rebate topic later this year. But we do have to, starting in 2026, when we bill the manufacturers for rebates for Part D drugs, take out from those units those prescriptions that were filled with 340B drugs. Just to sum up for the rebates, for B, we have to take out 340B units that was starting this past January. For D, we have to take them out starting in 2026. For B, as I said, we put out program instruction on how to do that. We've given some flexibility around 2023, but for 2024, our expectation is that providers who bill Part B for 340B drugs, Part B for 340B drugs will have a modifier, the appropriate modifier placed on the claim. So we take those out. For D, as I said, we've got some time to figure out what the right solution is there. Now, the drug negotiation program. Again, how does this affect 340B? Well, as I said before, what we're going to do is we're going to negotiate with manufacturers to establish what are called maximum fair prices for Medicare Part B and Part D drugs, for certain drugs. Now, for the first 2 years, for 2026 and 27, it will only be Part D, and then we'll bring Part B online with some additional Part D drugs in 2028. So we're going to pick these 10 drugs. There's a specific methodology that the statute requires us to use, and we're going to publish those. We're going to publish those drugs in September this year, and then we'll enter into a negotiation process with the manufacturers with the goal of publishing by 2024 the new, what are called maximum fair prices for these new Part D, for these 10 Part D drugs. So as the second bullet says, these MFPs, maximum fair prices, will apply for 10 Part D drugs beginning in the initial year of 2026. For 2027, there'll be 15 additional Part D drugs and 15 additional B and D drugs in 2028. So the number of drugs subject to negotiation will be cumulative, and in 2028, we actually can start renegotiating with manufacturers under certain circumstances. Now, Medicare has never been able to negotiate directly with manufacturers. So this is a pretty significant landmark law in terms of the life of Medicare Part D. Manufacturers have generally negotiated with the Part D plans for prices, for lower prices, but this is the first time that Medicare will be able to directly negotiate with manufacturers for the prices of certain drugs. And we must develop and use a consistent methodology for these negotiations to achieve the lowest maximum fair prices for these selected drugs. That is what was described in the guidance that we issued on this in March, and which will issue a final guidance sometime this summer to get ready for the negotiation process, which will start this fall. Now, the plans will be passing through, and the pharmacies will be passing through this lower price at the pharmacy, and it will also be the basis of the beneficiaries' Part D cost-sharing amount. So as you know, when beneficiaries go to pick up their prescriptions at the pharmacy under Part D, they'll pay a cost-sharing. Sometimes it's a flat amount, sometimes it's a percentage. The extent to which the MFP lowers the total price the beneficiary will be charged will lower their cost-sharing. So there will be there can be benefits to the patient as a result of the MFPs that we negotiate. The plans will be required to put these drugs, as we say in the guidance, on the Part D formularies if they don't have them already. Now, how does this work with 340B? So we know many of you serve as pharmacies and Part D plans networks. The statute says that there's a non-duplication provision. So it says that the manufacturer is responsible for making up the difference between what the pharmacy bought the drug for and the maximum fair price that we negotiate. But the manufacturer does not have to provide both a 340B discount and a maximum fair price discount. So there's a non-duplication provision. Many of you are able to purchase drugs at 340B prices, and those 340B prices tend to be very low. We're not sure how the maximum fair prices that we're going to negotiate will compare to the 340B prices. They could be lower, they might be higher. Part of that depends on, our ability to negotiate a good deal for Medicare beneficiaries. But what the statute says is there's a non-duplication provision, which indicates a manufacturer only has to provide the MFP that we negotiate or the 340B ceiling price, whichever is lower. So they're not cumulative. So what we say in our guidance that we released, the initial guidance, and we'll have, again, final guidance on this, is that if a patient comes in, a Medicare beneficiary, and they're receiving a drug that is subject to a maximum fair price, that's the price they should pay. If they're subsequently determined that the ceiling price is lower than that, because again, as we've said, it's not always the case that a beneficiary is known at the point of service that they're 340B eligible. The manufacturer wouldn't have to also provide a 340B discount on that drug. They would just have to provide the difference between what the 340B ceiling price is and what the maximum fair price was. Let me make sure everyone understands that. There's a non-duplication provision in the statute. This is to avoid basically a double dipping opportunity that a manufacturer would have to pay both a maximum fair price for a drug and a 340B ceiling price. Clearly, Congress wanted the beneficiary to have the benefit of either, whichever is lower. So if the beneficiary comes in with a Part D prescription and the selected drug has it's a selected drug and has an MFP, the beneficiary will pay the MFP, or the cost sharing will be based on the MFP. If it's subsequently determined, because it's not known at the point of service, that the ceiling price, the 340B ceiling price, is lower, then all the manufacturer has to do is provide the difference between whatever the MFP was and the ceiling price, so that delta. So again, just so you understand how Congress wrote the statute and how we're interpreting what they wrote, is that there's a non-duplication provision relating to MFP and 340B ceiling price. They are entitled to whichever price is lower. So to sum all this up, if I can, in just a couple short bullets. On the rebate programs, we have to exclude 340B obtained units from Part B rebate billings. We had to start doing that this January, and we have to start doing that for Part D in January 26. So 2 different start dates. On B, we've already issued guidance on the use of a 340B modifier for Part B. Again, these are the JG or TB modifiers, which had been used many years by hospitals for reimbursement purposes. We have received comments on the approach to exclude Part B 340B units and the mechanisms to exclude Part D 340B units. That's in the guidance I said we put out early this year on Part D on rebates that we expect to issue final this fall. Further guidance is coming by the end of 2023. So for Part B, we've already issued our instructions on how to do that for 340B entities, both hospital and non-hospital. For D, we proposed a mechanism that is a modifier on the PDE record. We got comments on that. And of course, those comments had a lot of mixed reaction to doing that. We'll have to eventually determine what to do about 340B units in 2026 for Part D, because we have to exclude them. For the negotiation program, the manufacturer only has to pass through to a Medicare eligible individual the lower of the MFP for the drug or the 340B ceiling price, but there should be no duplication. So again, this is maybe the first, or hopefully the first of many conversations we'll have around these 2 important programs. At the end of the day, the goal here is to make sure Medicare beneficiaries have access to the medications they need, that we potentially get them the lower price, and that we continue to give manufacturers an incentive to innovate. I appreciate the opportunity today to provide this overview. I may not have all the answers to the questions you have. If there are any questions about this, we can continue to work on getting you better guidance, and there may be situations that we haven't thought of, which would not be unusual. So again, I want to thank you for your attention today, and look forward to any comments or questions or discussion you may have.
Thanks so much for joining today. And John, thank you so much for that great presentation and giving us that important information about this new program. And remind you that a copy of the webinar and also a copy of the slides presented today can be found on our spotlight page at the American Indian and Alaska Native Outreach and Education website. That website can be found at go.cms.gov/AIAN, and you can find that under the All Tribes Calls tab. And as always, if you want to submit any questions to the Division of Tribal Affairs on this presentation or any questions that you may have in general, you can send that to our mailbox. And that mailbox can be found at tribalaffairs@cms.hhs.gov.